So we're going to talk about penile prosthesis and Peyronie's disease. My disclosure is that I am a consultant for Endo and the SMSNA, a member at large on the board of directors. Let's see if we can get this moving. All right, so surgical treatment for Peyronie's disease is well established, and for patients with intact erectile function, guidelines recommend penile plication as well as grafting. We know that many patients with Peyronie's disease ultimately present with erectile dysfunction. Up to 60% or more will suffer from anywhere from mild to severe ED. And in this setting, the gold standard is really the penile prosthesis with straightening maneuvers for patients who are highly motivated. Can we go to the next slide? Many of these patients with Peyronie's disease, in addition to their tunical scar, will have cavernosal fibrosis requiring extra thought prior to moving forward with a penile prosthesis. So it's recommended that you consider having the available instruments at your discretion, Uromix dilators, Rosellos, and then think about your access. Do you need a longer incision? Do you need a separate counter incision to get adequate exposure for these adjunct maneuvers that we'll be describing? And don't hesitate to offer these patients a narrow-based cylinder if the anatomy affords itself. So we're going to focus here on some general techniques, but an alternative technique that's really been popularized over the last decade or so has been the scratch technique. Paul Perito, Steve Wilson wrote some initial work on this. The idea here that you're internally disrupting the plaque with a curved blade and a nasal speculum. Oftentimes this is done via an infrapubic approach where maybe the exposure to that tunical plaque is more challenging otherwise. Go to the next one, please. So the focus of today's talk, what do you do when you encounter this in practice? So sometimes we anticipate that. The patient comes in and says, I have severe curve. But sometimes these patients come in and they've had ED for a period of time and you do not realize, or they do not realize, that they're going to have severe deformity. So what kind of options do we have? So the EAU guidelines recommend that in the setting of known erectile dysfunction and Peyronie's disease, that penile prosthesis with adjunctive straightening, including modeling, plication, or plaque incision with or without grafting should be considered. For patients with more mild or moderate severity deformity, penile modeling can be considered. Essentially, this is aggressive bending of the penis opposite the point of maximum curvature. The idea there is that you're stretching or fracturing the plaque fibers. This was originally developed and reported by Steve Wilson and colleagues, and essentially for patients with mild or moderate severity deformity, the results look quite impressive. Manual modeling alone had a success rate in the early reports of up to 86%. There's actually been some more recent publications suggesting that even more severe curvature actually can be appropriately modeled down to functionally straight, but there are some potential downsides to this approach. Specifically, there was an initial report of a 4% risk of distal urethral injury, essentially the pressure delivered to the fossa navicularis during the aggressive modeling. This isn't suitable for patients who have more complex deformities like indentation, where curvature correction alone may not fully correct the patient's bothersome symptoms. And many patients that we counsel want their penis back to arrow straight, and if we're getting them a functionally straight result, many won't be happy with that. So alternative options include penile plication. You can place the plication sutures via a variety of different techniques. You can place these in the OR initially before placing the prosthesis cylinders, or you can place the cylinders, see what kind of correction you get with cylinder placement and modeling alone, and if necessary, remove the distal cylinder tips and place the plication sutures so that you avoid that inadvertent injury to the cylinders. And these approaches are associated with satisfactory curve correction. Sliding technique and other techniques have been developed. The idea here is you're offering the patients an approach to optimize penile size, so restoration of what's been lost. Nearly all patients with Peyronie's will come in reporting significant penile length loss. That can be a really devastating part of this condition, and so these techniques have been developed to try to address that. This is an example of the sliding technique. You have aggressive mobilization of neurovascular bundle, the urethra. You're making large tunical incisions to try to stretch that tunica and give an opportunity for a larger size implant. And there have been plenty of successful patients that have undergone this surgery with experienced hands. But there are some potential complications. There may be an increased risk for temporary, on occasion, permanently numb glands, an associated orgasmic dysfunction, and we've all heard about that rare risk for glands necrosis. So patient selection and surgical experience is of the utmost importance here. SMSNA just released a position statement on cosmetic penile enhancement procedures. It was published in JSM last month. And as part of this, the sliding or various aspects or different approaches of these techniques were included. The suggestion was that these should be performed by experienced surgeons with an IRB oversight and still considered investigational because of the potential increased complication risks. So for the last couple minutes, just wanted to talk about plaque incision and grafting, and there's a variety of different approaches that have been described. Dr. Hatzichristodoulou has been really at the forefront in this technique he terms the PICS technique, which is a combination of doing an incision at the point of maximum deformity, coupled with use of this graft called Tacocil, which is a collagen equine fleece that has adherent properties, so you don't need to sew it in, as opposed to some of those other grafting materials like our allografts and our xenografts. So that saves time in the operating room, and it saves the potential risk of damage to the cylinders. So these are some pictures that describe this technique. So again, this is our patient from the start. This is our patient with severe residual curvature. So this was a penoscrotal approach. Dr. Hatzichristodoulou usually performs a subcoronal incision, degloving incision. Here's an example from the dorsal aspect, although you can certainly expand that ventral incision and mobilize the neurovascular bundle from below as well. This is just an example, so mobilization of the neurovascular bundle, incision of that area of maximum curvature. You can see those cylinders exposed, so we want to protect those cylinders, place that Tacocil, that self-adhering graft, or you can sew in a graft at your discretion, and then ultimately closure of the buccal fascia. You can see an excellent residual straight, essentially a completely straight penis here from the top and lateral views. Again, final view there. So this was a two-center experience with using the collagen fleece and at the time of penile prosthesis placement. And this was in 51 patients were included in this study, and the outcomes were at a mean of 11 months were quite good. About 96% of patients were satisfied with the outcomes. 12% had a residual curvature all less than 15 degrees, so what we would generally in the audience term functionally straight. There was a incidence of a bulge at that area of grafting of 8%, so that area is a weakened spot, and typically we recommend avoiding maximal inflation for a period of several months to try to allow that tunica to grow in and reinforce that weakened area. This technique can also be utilized for patients with severe ventral curve. So here's an example of a patient with severe residual ventral curve after implant. You can see the urethra needs to be mobilized to expose the ventral aspect, then make several incisions to relax the point of maximum curve, and then again place that collagen fleece. These patients need to be selected appropriately. So in conclusion, penile prosthesis placement with Peyronie's disease can be challenging. It's important to be prepared. It's important to have the appropriate counseling with the patient and to set realistic expectations. We do have multiple interventions that can correct residual curvature at the time of prosthesis if necessary. Some of the techniques may carry increased risk for side effects, so it should be done in experienced hands. And ultimately, this comes down to surgeon experience and patient selection to get patients the best outcomes. And with that, I thank you for your attention.